Several apologies. I have here Ian Wake, Stephen Course, but James Granger is here. Tricia Dorsey, but Karen Watts is here, so we are quorate for the meeting. Also apologies for Mark Burgess, Sally Watson, Andrew Bell, Lawrence Siemens, Deborah Deplin, Peter Taylor. That's the names I have. And as you will have seen, recording has started for helping minute-taking purposes. Declarations of interest. Does anyone need to highlight an interest in view of today's agenda? No. And we move on to review of the minutes of the last meeting. I take them in their entirety. So does anyone have a comment as to accuracy of the minutes, please? And if so, please raise your hand. No, then thank you very much, Kirsty, for preparing those. It takes us to the action log, so I'll ask Sadie to help guide us through. So Sadie, could you help, please?
Yes, of course. Thank you, Hein. The first action for Shepherd, he has been linking in with James and finance colleagues on this. They've made good progress on looking at how we can present the activity for LCSs. There will be an initial review of report of this being made available, which should be ready for the meeting on the 1st of October. So the suggestion is to close this one and add it to the agenda for 1st of October.
Yeah, sounds good. And there's always quite a bit of interest in these, so it would be good to see that coming to the next meeting. Thanks.
Lovely. Next one was an action for Tricia and myself. This was in relation to the future delegation of screening and immunisations from NHS England to the to all ICBs in the country. We had put this one on hold pending the ICB blueprint. We understand that the plan is still to delegate this from April next year, and I have been in conversation with the regional team about resurrecting the preparation meetings that were put on hold. I think because of the changes in capacity in ICBs in the future, it's likely that we will need a slightly different approach to delegation in terms of what can be achieved. I was suggesting in this one that we actually close this action and follow up through those regional meetings, bringing it back as and when we should. But we'll continue that dialogue with the quality team through Karen, through Tricia and colleagues, so that we can make sure that we're doing what we need to be doing.
Yeah, I think that's fine. Saw several notes on the screen.
Great, thank you. So the next one, 200, is done. 201. This was the 2-week performance data, which didn't appear to have been carried forward into the operational planning requirements this year. Shepherd's view is that regional colleagues haven't got any intel on this one, but suggest that we keep it under review with the other ICBs in the region. So he thinks that we should close it and monitor it as part of the work that we're doing through the GP action plan and the operational planning that we will come on to later in the agenda. Yeah, that's fine. Then the next one, 202, I think this was when Sarah Elliott attended for James. James has worked with Sarah to prepare the response in there. Again, this one's proposed to close. James has detailed there what the underspend and the clawback is for that one. And then the final one, 203, this was about the pharmacy budget, and there's confirmation there that the pharmacy budget is not ring-fenced, therefore the underspend was not carried forward.
Yeah.
Again, proposed to close.
Good. Thanks, Sadie. Any comments from everyone, or are people happy with the updates and closure of many of these? I take it as a yes. Thank you, Sadie. We stay with you for the forward planner.
Thank you. All items that are listed for this month are on the agenda, so I don't propose to add anything else unless there are any specific queries.
No, I think when we come to the GP action plan, I think it would be good to sort of monitor that frequently, but we'll touch upon that when we get to that agenda item, I suggest. So let me check with colleagues whether there's any comments people have on this one. No, thank you. That takes us to item 6, the risk register. Sadie, I'll come back to you.
Thank you. So you'll see from the report that there haven't been any new risks reported or raised this month that meet the threshold anyway to bring to committee. No changes to the risks that we've got already, and no de-escalations. So we're continuing to monitor the resilience of all of our primary care contractors. I think the thing that we're most conscious of is the potential now for the ICB's financial position to mean that we have to take difficult decisions, and that's not limited to primary care. That's a process that's ongoing right across the ICB for all areas. So at this stage, there is nothing to report on that, but we are currently working on options around potential commissioning changes as part of our financial recovery processes. And once that they have gone through the relevant processes internally, then we would at that point discuss any potential changes with our local representative committees.
Yeah. So I'll open up for questions and comments, but I recall last time we had quite a bit of discussion also with, I think, LMC and LPC around the impact of national insurance increases on resilience of respective practices. Any update? We said we would sort of keep a watching brief.
Yeah.
On this one.
We are still keeping a watching brief. We still are not receiving any Section 96 applications from general practice. We haven't had any individual approaches from practices, but we are aware it's kind of an underlying issue from the local representative committees talking to us about it, but we haven't yet seen any individuals sort of come forward with this as a particular concern.
Yeah. So opening up for comments or questions from colleagues on the risk register and the covering note. Lisa.
Thank you, Sadie. Yes, we do meet regular. We do remain concerned about the resilience of general practice. It is continuing to be impacted, and we are getting reports that funding is limiting availability and also impacting the services that can be provided. And the main concern is that the capacity is continuing, demand is continuing to far outstrip capacity all across Norfolk and Waveney, and that is the consistent message we are getting, and that there is still a real difficulty with recruiting both clinical and non-clinical staff. So it does remain a concern. Thank you, Sadie.
Thank you, Lisa. Any other comments? So is the committee happy to approve the risk scoring and the sort of underlying argumentation, and we'll continue that watching brief as we heard saying we take note of what Lisa said in terms of demand far outstripping capacity. Okay, well, minute accordingly. Many thanks. That takes us to item 7, strategic primary care workforce recruitment and retention program report. And I think, Ben, you will guide us through that. So can I hand over to you, Ben?
Yes, absolutely. Thank you. So the papers attached show our plan for funding to use for our workforce for general practice, optometry and dentistry for 25-26. It's a really exciting year. We've got a lot of programs focusing on the whole breadth of both clinical and non-clinical roles, looking at training, retention and recruitment programs throughout. The paper highlights as we go through the success of last year. In particular, one thing I've been really pleased with is the 91% of uptake of workforce programs offered in general practice, another 3% increase on the year before. And we've managed to get up to 93% of the GP practices now approved as learning organisations, which is fantastic. And then on a personal note, I'm very involved in all our dentistry work streams this year. We've been working very closely with the LDC and other stakeholders to come up with a really great programme, focusing on a whole range of different programmes from CPD through to first 5 development, as well as supporting commissioning with level 2 services, amongst other things. So we'll go through the paper in any more detail than that and open up to any questions or anything anybody would like me to elaborate on.
Thank you, Ben. And I should add, I did ask before the meeting that pharmacy seemed to be missing, but I think it's been clarified between Sadie, Michael and myself. The aim is to bring them back to the next primary care commissioning committee, so that we also have a strategic workforce view on pharmacy. So we will come back on that one.
Yeah, absolutely. I'll take that back.
Yeah. Lisa.
And thank you. It is a very detailed report, and it's good news that 91% of practices are taking up the training offers that are there. It is disappointing that there is a 12% reduction since last year for the funding to train, recruit and support in general practice. It is essential to maintain services and support staff across the wider system. We understand that the CPD funding is in addition to the original sum. However, it is important to note that irrespective of the funding initiatives available, clinical and non-clinical staff are very limited in some areas, specifically rural, and despite whatever initiatives are in, if the staff aren't available, they cannot be recruited to the more rural location, which would have a further impact on capacity and increased risk to resilience in general practice in the wider system. Thank you.
Is there anything you want to comment on it, Ben?
No, I totally understand, and focusing on rural areas is something that we are trying to keep as a golden thread through everything that we do. In particular, one of our programs this year, we're trying to make sure that someone in our team goes and has a face-to-face meeting with as many practices as possible, and making sure that we have those face-to-face and understand what is it that's stopping them from being able to take up any of the programs we're offering, and if there is other support available. And then we've also got a bespoke one for the dentistry side as well, to see those who didn't take up anything last year, what was it that was holding them back specifically in those areas, and is there anything we can do differently this year?
Thanks. Karen. Karen, you had your hand up, or just, you're on
so
mute.
My mic's off now, rookie error, sorry. Thank you very much for answering. I think Ben has answered my question quite thoroughly. But what I would like to know, if we got any particular hotspots, are we able to drill down to look at what we need to do in a more bespoke way for some of those more challenged areas? Do we have that later level of detail?
So something that we've built as a team is a regional map where we highlight every single program, what's been uptaken where, when, what and how. And also Jaden's very well tied in with the business intelligence team as well. And we started to build some really good dashboards that are starting to bring that information through. So that's something that we absolutely share in other reports and updates as we go through. And potentially might be something interesting to bring for our next update at this meeting to give that geographical, what does it look like over the last year. So I'll take that point away.
Yeah, that's a good suggestion, Karen, and I'd like to take you up on that when you, I think in January, I think is the next planned update. Provide a bit of perspective that we do look at regional dynamics, etc. Thanks. Sarah. You're on mute, Sarah, sorry.
Sorry, there we go. Same mistake as Karen. Thanks, Ben, for the paper. Has there been any further forward or any thinking about the non-clinical training and the workforce going forwards? Because for practices, this is one of the big areas, especially with the churn and the turnover of staff. And then the annual updates on clinical coding, any updates on QOF, LESs, new ways of using templates and stuff. It's every practice would be training their same. And I know practice managers previously have asked for this, but I know there's been an issue with funding, and I just didn't know if there was any way around that or if it was moving forward at all.
Yeah, absolutely. In our training needs analysis, we now include a specific area asking about what the non-clinical needs are as well, because we absolutely recognise it's the whole team we want to be supporting. And there have been challenges with funding, particularly around the CPD can only be used for clinical. So we've been trying to understand what we can do differently. And I will come back to confirm, but I'm sure one of our programmes does specifically look at that non-clinical piece and what it is we can do and understand. But I'll take that away and just make sure that I know exactly what that project is, and I'll send you the details afterwards, Sarah.
Great, thank you.
Thanks. Lisa. You're on mute, Lisa.
Apologies. I've received further feedback from Jade that she has received additional funding through grant applications, etc., to support non-clinical training, like Sarah was just asking, and there should be some further movement on that following the first TNA meeting on the 17th of July.
Brilliant. Thank you, Lisa. Appreciate that.
That's good news. Sadie?
Yeah, thank you for that. I just wanted to note that the reason the overall funding allocation had reduced is because our overall funding allocation was reduced. This is one of the budgets that we get from NHS England directly. We don't get a training hub budget for any of the other contractor groups, only for general practice, and it comes with a whole bunch of KPIs, and it comes with specific kind of rules around it. So as you'll have seen from previous papers, we have been able to identify funding non-recurrently to support our dental programme, but the team does do what it can to bring in additional funding to support optometry programmes as well, and the non-clinical training. And I know that Michael's team around the community pharmacy element is also looking at sort of how we can identify funding for that. So it is quite challenging for the team when the national allocation is really only focused towards general practice, but we do absolutely everything we can. And I think the good thing is, as Ben said, it's a really exciting programme. We've got fantastically good engagement around it across all of our sectors, and the team has been recognised nationally for the success and the difference that they've made in changing some of our performance data around retention of staff and so on. So well done, Ben and colleagues. It is a great programme.
Thank you. I think we all support it. If there's no further questions or comments, so there's several recommendations in the paper. I won't read it out loud, but people to happy to approve the funding as outlined and to note the information linked in the report and Appendix A. Not so many thanks for the update, Ben, and bringing this to us, and look forward to hearing progress when, I think in January, I believe, is the planned next update on this one. So many thanks for that. That takes us to item 8 on the agenda, strategic framework for primary care. Amanda, I think you will guide us through that.
Thank you. So I'll take the sort of paper and framework taken as read. Hopefully, since it last came to the committee, we've managed to capture and address the feedback that we heard then. I think it's probably useful to acknowledge that there have been a whole suite of announcements, policies, plans and guidance and changes since then. And it does feel a little as though you could rewrite it every single day to incorporate the next thing. But I think at the heart of the framework has probably always been, how do we develop a system approach to how we lead and work together across primary care? And so that's really where it started, and where I think it still is. We have put forward 4 work streams or areas that we think would benefit from focus over the remainder of this financial year. I think one of those is really about, Lisa referenced earlier, about that continual demand and how capacity, it is really difficult to keep up with that demand. So it's about having that collective understanding, what's the demand, what's the need, and what's the capacity, and how can we make sure that what we design and what we deliver going forward makes the best use of the capacity and the resource that we have got. I think understanding the role that primary care can have and the difference it can make on health inequalities is something else. And obviously that's joining up with a lot of work that's already happening in that area. I think building on that collective understanding then is how we get primary care input into the planning and the decision making, and that's from across all of our 4 pillars. And hopefully if we get those 3, we might then start thinking about that 4th piece of the jigsaw, which is, what does primary care need to look like to be fit for the future? So they're the areas that we're suggesting that we focus on. I think throughout that, we recognise that people's experience of primary care is really different, that the way they choose to access it or can access it, the way it's delivered varies, and we need to think about all those things in how we commission primary care going forward. So that's where we've got to. So the purpose of bringing the paper today was to ask if the committee have got any further feedback or comments they'd like to incorporate, or where they'd be happy to adopt the framework, and whether they're supportive of the 4 areas that we're asking to focus on for the rest of this financial year.
Many thanks, Amanda. Very clear introduction and clear paper. Karen, you have your hand up.
Thanks so much, Amanda. And it is really on shifting sands at the moment as the guidance comes down, isn't it, in line with the 10-year plan. I guess my question is, yes, absolutely support the framework, but in terms of the implementation plan, how will that be socialised across primary care, and what will that co-production look like?
So I think that will be probably having those conversations with everybody here. So it will be, you know, Fiona leading some of those discussions, that there will be, hopefully, in the same way that we had the engagement with different groups and individuals to develop it, we would do that and socialise it that sort of way, and think about as we do that how we might be able to move to that sort of collaborative space where people are coming together, so we can have those individual conversations, but also we have them as a collective, which is probably a bit of a shift for us.
Thanks. Any other comments or questions? Recognizing people had a chance to provide input on a few occasions. No, I've seen on the sort of page, I think 60 is in my pack, with a sort of literal roadmap that you are coming back at various points in the financial year with a progress update. So I think it makes a lot of sense. So is committee happy to approve the focus areas and the planned approach? Take silence as agreement. So many thanks for that, Amanda. And thanks for your hard work on getting us to this point. And looking forward to the updates later in the financial year. We stay with you and Sadie for item 9, which is two closely related parts, an update on the operational planning and then specifically also for the GP action plan. So do I hand over to you, Amanda, first?
Thank you. So again, this is we've discussed, I think, the operational planning at an earlier meeting in March. I know that some of you here will have seen the detailed GP action plan that we've had to submit. We're still awaiting feedback on that. And that does talk about a focus on 3 areas for us going forward. And it sort of breaks it down to improving contractual oversight, addressing unwarranted variation, and commissioning and transformation. And I suppose we've talked about this, and as we've socialised it, we've said, what does that really mean? And I think we've boiled it down to, it means we've got to make sense of the data available to us, and there is a lot, and it doesn't always triangulate how you would expect it to or how you would like it to. I think the second part for us as a team is really leading the discussions to explore what it's telling us. So again, we get that collective agreement about what are the opportunities, what are the challenges that we're going to focus on together, and then translating that into how we're going to use that collective expertise and resource that sits around the system across the ICS available to sort of leverage those opportunities and address the challenges, and do that in a way that it meets with our overarching objectives that are around improving access and experience and improving health outcomes, which are the goals I guess we all share. In terms of how we come back and we monitor that, I think there's quite a lot of mapping out to do in terms of there's what we've got in the GP action plan, which is mostly existing work streams. How do we feed that into that overarching operating framework, neighbourhood guidance? How do we layer the oversight framework onto that? We know that the next iteration of the plan for recovering to access to primary care is going to come fairly soon. We're expecting the red tape challenge to come very soon, I think, as well. And it's really how do we bring all those things together and bring them to this space to say, how are we doing? What does it mean? And where are we going to focus our collective efforts?
Thanks. Anything you want to add at this point, Sadie?
I don't think so. I think Amanda's covered everything very well.
Good. Let me open up for comments and questions. Ian.
Thanks, Hein. Yeah, Amanda, Sadie, just acknowledge the work that's gone into the paper, and also thank you for the collaboration with the LMC. Obviously, there have been some very helpful touch bases around the action plan. It's really just to also reiterate the point that we've made offline, that really good with the general concept of GP dashboard and data extraction. But already this year in 25, there are 4 separate known national NHS data issues, 3 of which have been sorted. 1 NHS Digital is still trying to get sorted. There are also some local data extraction issues with Ardens. So actually, we must reiterate that this is where you're looking at dashboards, that's the start of the conversation rather than data being taken at face value, because you can make data probably make a 1,000 different or different answers, different attributes from the data. So it's really just to make that point, but really good that the more information you have about what's going on the ground, then the better the commissioning can be, the better the working together can be, and the better that the patient outcomes, as has been said, the better the patient outcomes will be. Thank you.
Thanks, Ian. Karen.
Thanks, Hein. I agree with Ian. It isn't going to be, the dashboard is great, the more information you have, but if you're measuring patient experience, you also need the narrative and you need to understand what your patients are saying. So it's important that we listen and we include our patients in anything that we do. I know we do that anyway, but just being very implicit about that we don't just measure through one lens. Thank you.
Thanks, Karen. Well put. See, no further hands up. So on the recommendation, and I sort of messages to Sadie before the meeting, I think this is so relevant. I think Ian and Karen said it's not just about the data, but the narrative behind it, that I think we should make this a standing item. And I don't mind if there's an expression, perfection is the enemy of good here, and we should not fall in that trap. So it's fine if we sort of learn as we go along, but I think having it in front of this committee will help sort of to see what's working, what needs a bit more emphasis. So on that basis, I would ask we make it a standing item on the agenda, and then we'll find our way through it. I'm pretty sure. So that's the only sort of add-on I would make as part of a recommendation. But is committee happy to support the recommendation that you see in the paper? If there is not, many thanks. Many thanks, Amanda, for that. We're moving quite quickly through the agenda. Item 10, delivery group reports. We start with GP Community Pharmacy. Sharon, I believe you will introduce that.
I am. Yes, thank you, Hein. So I'll take the paper as written. This report is a summary of the meeting that was held on the 10th of June this year. Just a few key highlights to bring out. Key items for notings was around the LD health checks, which was the end of year report. I think it's important to acknowledge the efforts of the team and those involved, achieving a 76.8% uptake against the minimum national requirement of 75%. Some key items for approval was the General Practice Improvement Programme, or GPIP. Previous cohort feedback had been positive, noting significant time saving for clinicians and colleagues. So it was great to see that being approved. There was a 6-month extension approved on our British Sign Language services, which will enable a further procurement of the services going forward. And also August bank holiday commissioning was again approved, and for community pharmacy, they acknowledge the importance of this, and we also acknowledge the movement of the project to a recurrent model, which will hopefully be in place for winter 2025. There was also no items for escalation.
Thank you, Sharon. Very comprehensive. Any questions or comments on this delivery group report? No, thank you. Then 2 on the dental side. Sharon, I believe you will introduce these.
Yeah, I think it's SJ, Sarah from the dental team will be doing it.
Okay. Sarah.
Yeah, so I'll just take you through these reports. So the first one is our dental development group. That one is they are not a decision-making group, so they will pass on recommendations and thoughts, but they are not a decision-making group. So the last meeting was held on the 20th of May, and the key items we talked through year 2 of our long-term dental plan ambitions, and we had quite a good conversation. So other areas in the east of England have done some care homework, so we talked about that and how that could potentially impact what learning we could take from that. And we also talked through some of the workforce recruitment and retention plans, which obviously Ben's gone through some of that with us today. There was no items to be raised from that meeting. So that's that one. And then I think we go straight to me for the next one, which is Dental Services Delivery Group. So this one is the decision-making group. The last meeting was on the 10th of June. Key items from that one. We did discuss, we had an update from the Secondary Care Recovery Programme lead that is led by Suffolk and North East Essex ICB on behalf of the East of England. So there is some work happening there, particularly around TMJ and the referral processes and oral surgery. We did also discuss the workforce plan again, so we went through that and everything, all of our plans being approved through Triple Lock, so that was fabulous. So we made got some approvals from the Dental Services Delivery Group, so that was around the dental contract assurance framework, so that's the framework in which we monitor our dental contracts. That works very nicely against the GP one, so it's a fairly similar document. We received approval in terms of a GDS contract, that they had a change in their clause for that one, so that was approved. They approved the governance arrangements for working with Norfolk County Council. That is around the supervised toothbrushing scheme. The money has gone to the council, so we will procure it, but there is an agreement been put in place to make that happen. There was an approval around some commissioning plans to increase our unscheduled care capacity in line with the national target. We are looking at some proposals in terms of some contract amendments to stabilise those practices, that particularly in rural, coastal and areas of high deprivation, where they particularly struggle either with the kind of level of need of their patients that they're seeing, or just in terms of recruitment. So there's some work around that has been approved, and there was a 6-month extension approved of the interpreting and translation services contract. There were no items for escalation though.
Very good, many thanks, Sarah. Any questions or comments on those two reports? Karen.
Just to say, I think they're really comprehensive reports, and it really covers the breadth of the meeting, having been at both of those meetings, and it demonstrates the breadth of work and the progress that we're making. Even though it is massively challenging, we're still making progress, which I think we should really acknowledge. We're very good at saying when things don't go as well as we would like, but people have worked incredibly hard across the system to improve things in those areas. Thank you.
Yeah, well said, Karen. Jason.
Thank you, Chair. It was really about the interpreting and translation service. That's not something that I have made an enormous use out of during my career. I've just been quite fortunate with my patient base, but I appreciate in other parts of the county, other providers may make far more use of that service. And I wondered how much we'll be engaging with service users to determine what service is used going forwards.
Sarah, can you respond to that? Or Sadie?
So I think the reason for requesting the extension was to do just that, Jason, because I think you've done quite a lot of engagement with the deaf community around non-spoken languages, for example, but less around spoken languages, and we definitely get less direct feedback as an ICB around spoken languages services. So this is something that Shelley Ames is supporting the team on, and she's our head of health inequalities. and VCSE partnering. So ideally placed to do some of this work with us and looking at Community Voices programme to support with that. So yeah, it's a really good point, and why we wanted to enact that extension that was already provided for within the contract.
Thanks, Jason.
Yeah, it was just to reiterate the balance between patients and the fact it's safe and effective for them, but also whether or not it's actually fit for purpose from a clinician's perspective. You know, if you can't book a translator at the time you need it, then it's not helpful for anybody. So as long as we're seeking that input from, you know, in a circular fashion, then I have absolutely no issues at all. Thank you very much.
We are in the process, sorry, Hein, if it's
Yeah.
okay.
Yeah.
We are in the process as well of making sure we've got all the latest data from the providers, because they do have to report when they can't provide. And very often it's easier for the providers for routine appointments. It's very challenging when you try and get an urgent appointment covered. But you know, what we can't do is end up with a two-tier service, just because you know, you struggle to access services because of your language requirements shouldn't mean that that doesn't mean that you can't get quick and accessible care when you need it. So that is definitely part of the focus that we're taking.
Good, thank you. That concludes the Dental Services Development Group reports. That takes us to item 11 on the agenda. So James, over to you for the finance report.
Thank you, Hein. Yeah, so as usual, I'll take the report as read, but highlight some of the key points in the report. So beginning with the exec summary, we're currently reporting the directorate as being £3 million overspent for the full year. As you can see from the waterfall graph on that page, that the breakdown of this variance, apart from some immaterial overspends in LCS and Optom, the only existing problem is the delivery of the £2.96 million efficiency requirement that is built into the primary care budgets. So as at month 2, we had not validated any of the savings that are currently being worked on against that £2.96 million requirement. However, we can report that a £500,000 forecast for the work being done on moving APMS contracts to GMS will be included from the month 3 number. These include full year savings for the St John's conversion worth approximately £250,000 and savings badged against the Walk-in Centre and Norwich Health Centre contract price reductions for 25-26, where an efficiency element was negotiated with the provider, that provides the remainder of the £500,000. A full list of potential savings has been submitted to the Financial Recovery Group and has been RAG rated based on the ability to deliver by the commissioning team to meet the remainder of that £2.5 million efficiency target. And both teams are working together to find a solution to meet the overall financial target. Other areas included in the pack is the LES activity tracker, but due to the quarterly nature of the claims that we don't have any information yet to provide the utilisation of that budget, but that we brought back into future reports as we get the quarterly information in. In addition to the reported finances, the finance team also collate a list of financial risks and mitigations, trying to preempt some of the potential financial risks that could occur. Currently, some of the areas that the team have some concerns over include the following: weight management drug overactivity, risk of losing dental allocation as has previously happened in 24-25, the risk of non-delivery of the efficiency target, both the sustainable commissioning 3 million and the prescribing 14 million, so an aggregate of £17 million, and then finally GP hardware and system overspend. These have all been included in the month 2 R&M schedule, which is submitted to the ICB's Finance Committee. So that was all of the areas I was going to highlight. If there are any questions.
Thank you, James, and thanks for highlighting the efforts ongoing to identify what is as yet unidentified deficiencies. Any questions for James? Recognize it's early in the financial year, but good to see the report. No, many thanks for the update, James. Then we move to item 12, the internal audit report. I think, Sharon, you will walk us through that.
I am, yes, thank you, Hein. We'll take the paper as noted, and just to acknowledge there is a paper and also the actual audit report as part of the paper. The purpose of the paper is to inform the committee on the outcomes of the internal audit and to seek agreement on the recommendations and actions being taken. The focus of the report on this year was on the implementation of the April 2024 recommendations and also assurance against the NHS England primary commissioning assurance framework, of which we need to self-declare every year. There were 3 important risk areas where action should be taken at the earliest opportunity. There was 3 routine risk areas where action should be taken, and no urgent control issues were found which would need more immediate action. These can be noted in more detail within the report. The findings acknowledge the continued hard work of the primary care commissioning team in their delegated responsibilities and also in their embedding of the primary care services into the ICB governance framework. The audit outcome shows there is reasonable assurance on how the risks are currently being managed. Happy to take any questions.
Thank you, Sharon. I'll open up for questions, but one of the recommendations is around, let me read it out, the ICB to establish goals for additional roles reimbursement scheme, how value for money can be measured across the PCNs. And I know the due date is set a year from now, because I think there's some work involved to set that up. But is there any national guidance to help with that, or national guidance coming forward to help do that, or are we going to reinvent something that maybe another system has already done for us?
I believe, I believe Jade is leading on this, so I may have to just pass over to Sadie. I'm not sure if she's more updated in terms of the question. As I say, Jade Robinson within the workforce team was leading on this particular recommendation. Sadie, have you got an answer to the question, or do I need to take it away?
I think partly, so you might need to take it away. I know that Jade has been doing a lot of work to look at baselines and claims with PCNs. I think the difficulty obviously is that no PCN is identical, and so they've all set themselves up in slightly different ways. And we do now have a different way of claiming for ours reimbursement, which James can probably elaborate on a little more, but we've moved towards an evidence-based claim. We started out with a very high trust process, but now we require upload of evidence, and this is, I think, in line with what others are doing regionally and nationally, and was advised by our auditors. So we know that ours claims are as correct as they can be.
Yeah. I will take it up with Jade. No need for an action, but I'm just curious how she plans to go about it. So I see a few hands up. Karen.
Thank you, Hein. Thank you, Sharon. I guess, Sharon, it's a quick question around the timelines. Are you confident that you will achieve within the timeline set for the important risks?
Yeah, I think particularly, I mean, one of the recommendations around the pharmacy dashboard has already been completed. That was quite timely in terms of the end production of that in time for the audit. So I think we did, when we did the return though, we did put a caveat in there around the organisational restructure and how that potentially may hamper our ability to complete the commitments that are made within the report. But otherwise, potentially we feel that we would be on track for everything.
Thank you. Colin.
Yeah, just to follow on Sadie's point, so I think this originally came up because they did an advisory hours audit for us a couple of years ago, didn't they, where we had issues, Sadie? And this was kind of secondary request there. The first one being we moved towards the evidence base, which I don't think there's even many other ICBs are even doing that. When we spoke to colleagues, they had a lighter approach, however we've gone for the full kind of evidence back. But from memory, it was more around if you've got, I don't know, 5 healthcare coordinators at PCN1, how do you know that they're the best use of that money? So I'm not really sure. I don't think we addressed that when we did our audit, because we focused more on getting the process in. But I wonder if that's how they're coming from. I'm not really sure how we can prove that. But I guess, like you said, Jade would probably be the best person.
I made a note to talk to Jade in the period ahead. Thanks, Colin. Nick.
Yeah, I was intrigued about the first of the routine concerns that related to dental, and it states that there was control gaps included lack of in-depth knowledge about the resilience and stability of all dental services across Norfolk and Waveney. Now, I've worked with quite a lot of organisations as they get churned over in the NHS, and I don't think I've worked with an organisation like Norfolk and Waveney ICB that has a greater knowledge and in-depth knowledge of what's going on with their contractors. Is this a historical concern, or is it still something that the TIA were concerned about? Because I'm a bit mystified as to why this has actually been flagged up.
I think in terms of my experience of the internal audits is around your ability to evidence the stuff that you are doing, and I think in terms of acknowledge your support of the dental team and the work that they do. I think it may just be, as we develop the processes we do around governance and what we do, it's about how we evidence and are able to evidence the work that we've done. So without knowing too much of the detail, and I do apologise, and I can pass this on to Fiona, it may just be that we weren't able to evidence all of the work that's been done to ensure assurance on that particular recommendation. I could just see that Sadie's put her hand up as well, so she may have some further information.
I was just going to agree with Nick that I think this is a bit of a legacy issue from when we received delegation. I seem to remember that our operational risk around the resilience of dentistry has this in the gaps in controls, about that understanding of resilience right across the patch. But I agree with you, I think that has changed. When Sharon feeds back to Fiona, we can just ask her to double check that wording in the risk again to make sure that it is our updated position, and if it has changed, then to just evidence that through the risk reporting process.
Good, many thanks. So Sharon said we're here to know to report and provide support for the recommendations and management actions. So is the committee happy to do that? I see not, so thank you very much, Sharon. That takes us to AOB. Anyone? No, I think this is my fastest part one meeting. I'm not sure whether that's good news or bad. Thank you everyone for joining. For those joining part two, let's take 12-minute break, reconvene 25 minutes to 3 on a separate link. Anyone who's leaving us now, thanks for joining. See you on the next occasion. Bye.